Welcome to Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our goal is to provide a platform where we can educate, advocate, and inspire women leaders to lift as they rise. With every episode, you'll hear from her as we showcase the perspectives, insights, and experiences of women who are leading the way in advancing women's health and empowering the next generation of women in healthcare.
Welcome to today's episode of Medscape's Women in Healthcare Leadership Series podcast. I am Christy Rohani Montes, Director of Clinical Strategy for Medscape, and I am so pleased to be joined by Antonella Chada Santuccioni, who is co-founder and CEO of the nonprofit Women's Brain Project in Zurich, Switzerland. So welcome, Antonella.
Thank you so much.
And also such a pleasure to have Visha van der Vlier, Professor and Scientific Director of the Alzheimer's Center in Amsterdam UMC in the Netherlands. So welcome, Visha.
Thank you. Pleasure to be here.
Excellent. And today we're going to talk about sex and gender differences as they relate to neurological and psychiatric conditions. The problem of equating men and women when it comes to medical management, and also women's careers in neurology and psychiatry practice. And I want to start by asking you both how you ended up in your career. And I'll start with Antonella. So oftentimes there's a professional reason, but also a personal reason, right?
Well, I would say that indeed, in my case, there were both professional reasons and personal reasons. The professional reason were due to the fact that I have done neuroscience, psychiatry, and originally I studied medicine, of course. And I also worked as a regulator for a Swiss therapeutic product agency approval. This means assessing efficacy and safety profile of drugs to be approved for the Swiss market. And this is when I started to realize with my eyes, having the privilege of seeing the whole clinical developmental data set of drugs to bring on the market, that there were significant differences often between men and women when it was about efficacy and safety profile. So this is mainly the professional reason. The personal reason, well, I have to disclose that at the top of my career, when I was a young doctor working as a psychiatrist, I also had the lack of marrying and expecting my first child. And with big surprise, I found out that my first, let's say, child was an anencephalia. And when trying to understand the reason why it happened to me, a brilliant doctor in the middle of her scientific career, I find out that anencephalia is more frequent in the female fetus. So that was the reason why the female brain, it is more sensitive, more prone to have all this type of brain and mental diseases, including developmental issues, neurodevelopmental issues when still an embryo or a fetus. And this was the real personal call. Of course, I'm also a woman. So when I found out that there was a gap, I said, okay, let's fill it in. That's it.
And Visha, how about you? How did you become sort of one of the really leading experts in cognitive decline and dementia?
Yeah, well, I think when I look back, it kind of just happened. And it started out with a fascination for how the brain works. And I ended up studying psychology, actually, neuropsychology, and being fascinated by how the brain works. And at the time, I had an internship at a memory clinic where I was a neuropsychologist. And I was fascinated by the stories of the patients that I tested at that time. And at the same time, I realized that the research part, so the scientific part, was more fitting for me than the testing of the patients. So I also made sure that I had a registration as an epidemiologist, and then had the opportunity to start after my PhD thesis at the Alzheimer's Center in Amsterdam. And I've never left since. And so I think because I realized that when you're fascinated by how the brain works, it's best study it in brains that do not work properly. And with Alzheimer's disease, it's really clear that the brain gets broke. It just breaks down. So that's offers an opportunity to study the workings of the brain. And from there, I never left. I love the field, and it's very important. to see, because it's such a huge disease. It affects a lot of people worldwide, particularly women. And then it's also interesting, I've always realized that whilst my career went on, that more often than not, you see that you're surrounded by more men than women professionally. And this has always surprised me a bit. But I think things are changing slowly, and that's good.
Good. And just sort of to follow on that point, why do you think it is that we're seeing these differences? What are the challenges really for women in getting into neuropsychiatry?
And I'm not entirely sure, because I think actually for getting into neuropsychiatry, there's not that many challenges, because the number of young professionals being female is far larger than those being male. But as we progress on the career ladder, so to say, then something goes wrong. And it's very difficult to see, because it's not very obvious. It's not that I saw a clear door closed or a wall, but yet it's also very obvious. So I think that men are more likely to choose men to follow them because they're more alike. So it's very important for females to also support each other. And then being a female, I'm also too familiar with the idea I'm probably not up to this. Perhaps I wouldn't be good enough. And that's something that I think many females have. And again, this is why we need to support each other, because we always have to think, well, perhaps I'm not good enough, but that other person that happens to be a male would also not be good enough, then better that I do it. So that's a way of thinking we have to get more familiar with and really empower women, and make sure that we have equal representation in our field.
And I think, there's something to say also about the stages of life that women have to go through, right? I mean, Antonella, I think we had previously talked about, those younger ages you might be dealing with pregnancy, with the child, and then with your parents as well as you get older. And there are all these sort of potential obstacles, I suppose.
Absolutely. I think that I'd like to start, first of all, with a statement saying that medicine has been mainly done by males so far. So it is a discipline that had mainly male hands writing medical books. And it is time to revert the narrative. So we need more medical leaders that are female to remove the biases that are embedded in each of us and to which Lisa pointed at. If I am a woman, I will be more sensitive to female issues than if I'm a man, and the other way around. I think this is known, and it's reflected also in differences when it's about ethnicity and underrepresented community. We need more outstanding leaders from underrepresented community, whether it is the female one or ethnical differences, to rewrite science. This is my motto. And when it's about then the life trajectory that a woman has to face versus the one of a man, there are certainly profound differences. We just had released the UN Women Report and the DISA report. What they state is that while women tend to live those few years longer than men do, they have much poorer quality of life in terms of health. So they tend to live with much poorer health than a man will do. We have more comorbidities, more chronic diseases, and this has, of course, an impact on the life outcomes. When about the caregiving role, most of the time it is the woman taking care, and it's often unpaid caregiving. And the life has changed to a point in our modern society, especially the Western society, that there is a completely, let's say, different trend than what my mother had as a mother, if you know what I mean. So we tend to have kids much later, especially if you are a highly professionally skilled individual as a woman, and you want to finish your study and you want to get a good job. So we become mother much later. Our kids will become teenagerhood when we get into the phase of premenopause, menopause, and at the same time, our parents will become in the need of care. So it accumulates to a point that quality of sleep, that chronic stress, that still juggling the high career peak, because with 40, we're still in the middle of our career. These represent a type of stress that, as I said, so far has not yet been studied. There are no discussion about this big elephant in the room, and we need to address it to understand what we are doing to ourselves.
Absolutely. Yeah. And issues that men don't face at all.
Well, that's I think very important, if I can add to that, because I think one of the things that would really be so important is that men are involved in childcare and also get paternity leave, for example. And I think Scandinavia has the countries that have a longer history there and really do better in equal distribution of the care burden. So I very much applaud that men can also take paternity leave. And this is now starting to change in the Netherlands. It's really the only way to make sure that the burden of care at home is equally distributed. And the same holds for taking care of your parents. So in the Netherlands, I think worldwide, we see this huge challenge that the aging population, and that there's actually too little hands to take care of our elderly. And in the Netherlands, more and more the government is saying that the informal caregivers should really take on more work. And it's not yet being mentioned that these should also be the men. And this is, of course, very important that this is going to change the picture that Antonella has just made, that it will not only be the daughters, but also the sons taking care of their parents.
Absolutely. I think that's a great model, and hopefully other countries will look to the Netherlands and some of those more advanced countries to implement those kind of things. I think a lot of countries are way behind, though, not providing paternity leave and that kind of thing.
Even in the very Western developed society, there are countries which are very much behind to the Nordics.
And it takes such a change in culture, because I remember my first male colleague saying he would work one day less a week or would take time off to take care of his children. And people would really look at him with strange eyes. Well, it should be normal. Everybody throughout the organization, throughout the country should find that normal, because otherwise there's no way that women can take the stage like men can. Yeah.
Yeah, completely agree. I want to switch gears a little bit and look at sex and gender differences in medicine. But I want to start just with defining the difference between sex versus gender. What do we mean by that, Antonella?
When we refer to sex, it is about what it is embedded into our DNA. When we refer to gender, it is what the society or the individual decides to be represented as such with a given role, whether the male role or the female role. So it's more of a social construct, and how the individual is embedded within that, either because of its own choice or because of the role given by the society.
And then just looking at some of the neurological and psychiatric conditions that affect women more than men, and vice versa. What are some of those conditions, and why are they affecting men and women differentially?
Well, the list is unfortunately very long. We have that the female brain, because of biological but also societal reason, apparently it is more prone to get brain and mental diseases than the brain of a man. And we talk about major depressive disorders, anxiety. We refer to migraine, to Alzheimer's disease, multiple sclerosis. We even have that there is a specific predisposition of the female brain to get the so-called anti-NMDA receptor encephalitis, which is 80% female, if not more. And it's about not only prevalence, but it's also about differences in symptoms, progression, treatment response, profound differences in treatment response between men and women when about mental and brain diseases. And this is still very poorly studied and understood, and especially it's not considered at all in clinical practice. I mean, time to diagnose for women with multiple sclerosis might take up to 5 years, even in healthcare system advanced as the one I'm living in, which is Switzerland, because at the beginning, a woman is thought to have depression, stress, you fought with your husband, maybe you have labyrinthitis, maybe you have vertigo because of whatever reason. In the end, it's found out this is an MS, a multiple sclerosis after an MRI is done of the brain and you see the plaques. So, just a little bit of an overview. And yeah, there are profound differences between men and women when about brain and mental health.
And what about in Alzheimer's disease, Reshape?
Yeah, that's what I was thinking about. So when we think about dementia, Alzheimer's disease, most common type of dementia, that's more prevalent in women than in men. I think 60-70% women and the other part is men. But in younger onset cases, so when the disease starts before the age of 65, it's 50-50. And for example, dementia with Lewy bodies is almost only in men, hardly occurs in women. And in fact, we don't have a clue why. So that's really interesting. And what I find interesting about Alzheimer's disease also is there's, of course, differences in sex and also in gender. Because when you have Alzheimer's disease, the most prominent signs and symptoms are cognitive decline. And that is, of course, has an impact on your daily functioning. And the daily functioning of men and women is different. And then I also realized that there's a difference in the gender or the sex of the caregiver, because a male caregiver might be less perceptive of his wife declining than a female caregiver being perceptive of her husband's declining, subtle initial decline. And these are very important differences that we're that we're only at the beginning of understanding. And I think it's good to realize that there's more female Alzheimer's patients, but there's also more female Alzheimer's caregivers.
And I may add that differences in Alzheimer's between men and women also go towards the progression of the disease. Women are known to progress twice as much as men in terms of time to decline. We also know that symptoms differ profoundly. Very often, especially in the early phases, patients comes to our attention with signs of depression when they are women. For the male population, it's more aggression and even alcohol consumed. So women also tend to be more delusional than men. And this type of differences often brings to the result that women are overlooked or diagnosed too late. Because at the beginning, they think, oh, this is depression. And the patient gets treated a couple of years for depression. And then they find out, oh, no, this is cognitive decline. Another reason it's because women compensate in terms of verbal productivity. So they mask the symptoms in a way at the beginning of the disease. And this is also a problem then that gets into how we enroll the patients in clinical trials, meaning that very often, while we think that the disease, it is at the same level at baseline at recruitment, it might well be that women have more brain atrophy, they are more advanced with the brain pathology and biomarker deposition in the brain. And, this reflects then at the end of the trial when you have to do your readout.
Yeah, it's also very interesting, for example, that we know that the amyloid beta and tau are the two main pathological characteristics of Alzheimer's disease. But given the same level of amyloid beta and the same disease stage, clinical disease stage, women have more tau pathology. So it seems, and this fits with what Antonella is just saying, so it seems that they have more advanced disease while presenting with a similar disease stage. And that may also be an explanation of why they may have more cognitive reserve, being able to deal with it for a longer time and then decline faster once the diagnosis is clear.
And Antonella, what are some of the issues with clinical trials?
I think that the real problem starts in preclinical research, because what happens in the laboratory with mice, it is still a mystery. I mean, not everyone is consistent in disclosing the sex of the animals used for experiments. Not everybody includes enough women in the experimental setting within laboratories, because there are all sort of prejudice on female mice, having these menstrual fluctuations.
This has greatly amazed me when I heard that for the first time, that actually in preclinical studies, they prefer to have male mice because female mice are annoying because they have a cycle. And you think, this can't be true. Of course they have a cycle.
And we also, as female, we have a cycle. And we know that all these hormonal changes even influence not only on the symptoms of a disease, but also on the way a patient responds to a given treatment. This is true for Parkinson patients. If you speak to them, they'll tell you, I know very well how my drug will work in a given phase of my period, especially if they're still in the fertile phase, young patients, right? So I think we need to change again the narrative. We have to do it ourselves, and we need to be empowered to do that, to achieve precision medicine, bring better drugs on the market, avoid profound numbers of side effects in the female population. And then the same is true for the risk of reducing withdrawal of drugs from the market, because that's also another big issue that it's a burden for everyone, from drug developers up to the patients who might benefit of a drug.
I'm not sure that people are aware of how many drugs have been withdrawn because of side effects in women. And these are differences that are not looked at in clinical trials.
So what we can say is that one report dated 2001 from the General American Accounting Office pointing to the number of drugs which were withdrawn from the market till then, within the last 10 years, I think. And surprisingly, out of 10 drugs withdrawn from the market, 8, it was mainly because of lethal side effects in the female population. And what we know today is that additional drugs that have been unfortunately withdrawn from the market, but apparently majority of the information available to the scientific community do not disclose whether this is because safety profile were more in the female population or in the male population. This morning I did again a search to see latest publication, and you have publication that look at withdrawal of drugs from the market in 2020 or in 2019. And they make a wonderful list explaining that it's because of cardiovascular events, that it is because of mainly hepatotoxicity. Nobody did an analysis by sex and gender. There are no data discussed as whether it's more in the female or in the male population. And I know that it's very often more in the female because I was doing the job of a reviewer, because we know that QT prolongation are more female, because we know that hepatotoxicity is also a female issue. But the fact that publications get pushed out and shared with the scientific community, and they do such a huge meta-analysis and review of the existing data, and they don't disclose about sex, I just wonder. How can that be? Sorry, I'm really passionate, Vija, about this topic. It's
super interesting.
It's my battle.
And knowledgeable as well. You know so much about it. Very impressive.
It's my personal battle, to fix the issue.
No, and it gets more and more attention, so that's really good.
Fantastic. Well, I want to thank both of you for joining us. And to our audience, please look out for our next episode in the Women in Healthcare Leadership series.
Thanks for joining us. Tune in next week as we continue our journey to amplify the voices of women leaders in pharma and medicine. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next week, remember to lift as you rise.